Be performing my lung lab exam video. So the first thing I want my patient to do is be seated or lying down in a supine position. I'm going to be first checking for their blood pressure. So I want their arm to be in line with their heart, and then I'm going to be making sure the cuff is placed correctly on their arm. So to do so, I want to make sure the artery marker is above the brachial artery. I also want to make sure the cuff is about 2.5 centimeters above the cubital fossa, and I also want to make sure that the cuff is not too tight but snug enough to allow two fingers to go underneath it. Then I'm going to be palpating for the targeted systolic blood pressure, and I'll take my stethoscope. I place it on the brachial artery, which is medial to the biceps tendon, and then I will pump up to the targeted systolic pressure, and then slowly deflate the cuff around 3 millimeters of mercury per second. Then I'll take down my systolic and diastolic blood pressures in even numbers, adding or subtracting 5 millimeters of mercury per second um, as well too. After I do that and take my blood pressure, I'm going to be doing my inspection. So I will get up and look around, but the first thing that we're going to be inspecting for is rate, rhythm, and depth of respiration. So rate has to do with like tachycardia, that could do with pleuritic chest pain. Rhythm has to do with like sheen stroke, which is to do with stroke, and then there is depth, which can do with hyperventilating, which can be due cause from like someone having an anxiety attack. Then I'm going to be locating the bony thorax and looking for the shape and symmetry. So with that, I'll be looking all over. I may ask the patient to put on their gown or pull up their gown, also shielding their breasts, especially if they're female. And basically, when it comes to shape and symmetry, we're going to be looking for barrel chest, which could be due to COPD, or we can look for scoliosis, which can due to which is congenital basically. Then I'm going to be looking for any rashes, lesions, masses, or scars. Once again, asking the patient to pull up their gown or pull it down, looking all over. Some examples of this would be something like poison ivy, which can be due to contact dermatitis, or in a mass, it can due to lipoma, which is a benign tumor of the skin, which has a bunch of fatty tissues in it. After that, I'm then going to be checking for contraction of the accessory muscles of insertion. And that's usually on the front side, so we'll be looking at the SCM muscles as well as the scalene muscles. And then I'll be also looking for inspiratory accessory muscle recruitment, which usually has to do with emphysema. Then I'm going to be going on to my palpation, so we can start posteriorly. I'll ask my patient to breathe normally, also shielding their breast as well too, in the front. But basically, I'm going to be using the ulnar ridges of my hand, and I'm going to be doing 4 to posterior and 3 to anterior. So 1, 2, 3, over, and then anteriorly 1, 2, over. So now, if I deem that the palpatory reproduction of patient symptoms, if I find that there is any the reproduction of the patient's symptoms, then I will deem that as a chest wall issue. Then I'm going to move on to performing the chest expansion test. That's going to be posterior. So I'm going to use my thumbs around T10. And basically, I'm going to ask my patient to breathe in and out. My fingers should not be moved outside of the patient's breath. So they should not move anywhere, be moved outside of the patient breathing in and out. And basically, a normal chest expansion would be around 2.5 inches. But if there's any unilateral lag or lack of initiation, this is a form of pathology, and that can be also caused from pleural disease. Basically, one may go up, but the other may lag and stay behind. So that's how we're going to be checking for chest expansion. Moving on to tactile firmitis, similar to palpating, but this time we're going to be asking the patient to say the word 99 in a deep voice. So once again, to the back, 2, 3, 4, and each time I'm doing this, they're going to be saying 99, 99, 99 in a deep voice. And next, I'm then going to be checking for tracheal deviation. So we're going to be looking basically below the cricoid cartilage, and the SCM is where we're going to be looking around. And I'm going to use my 3 digits. So I'm going to first ask my patient to turn their head to the right, and I'm going to place my 4th digit lateral to the SCM. Then I'm going to ask my patient to put their head to the left. And I'll put my second digit lateral to the SCM, basically on the sternal head. Then I'm going to use my third digit. I'm going to ask my patient to face forward. And it's going to be basically come down the trachea, and it's going to go around the sternal notch, and this should be within the midline. So if there is ipsilateral tracheal deviation, that can be a sign of pleural diffusion, or if there is contralateral tracheal deviation, that could be a sign of a tumor. Moving on to percussion of the lung fields, we can start with the posterior side, but we're going to do posterior anterior. So with the lung fields, there is going to be 14 posterior and 12 anterior. I'm going to be using a reflex hammer, and then I'm going to be using the dip joint of my finger and striking the dip joint of my finger with the reflex hammer. Something to know is that the technique should be elicited good resonant sound. So if there is not, or if there's any pathology or abnormal lung sound, there would be some form of dullness, and that can be a sign of pneumonia. But anyways, we're going to go ahead and percuss, do my percussion. So and then on the anterior side, we're going to do some above the clavicle, one above the clavicle. I may ask my patient to pull down their gown a bit so we can do the rest and pull it up. All right, and then we're going to move on to percussion of the diaphragmic excursion. So that's going to be on our posterior side. So I'm going to use the reflex hammer once again onto the dip joint of my finger. And in this case, I'm going to ask the patient to breathe normally. And we're going to go from resonance to dullness. So we're going to go down. And this should be around T10. And I'm going to use my wax pencil marks to mark that. And then I'm going to ask my patient to breathe in and out again. But this time they're going to be holding in their in. And we're going to go superior to that marker, but we're going to go even duller. Once again, marking it with my wax pencil paper. And then this time I'm going to ask my patient to breathe in and out, holding in their out. And then we're going to go up, making resonance. So making my marker here at the resonance, which is going up. And it should be within the range of 3 to 5.5 centimeters when I'm measuring. I'm also going to be doing this on the other side. So once again, I'm just going to do it quickly over on this side. So going down around T10 area, marking, superior to that, go down and down. Patient is holding their breath in, marking, and then resonance going up. Patient is holding their breath out. Marking should be within 3 to 5.5 centimeters. So once I finish that, something to also note is that if there's any absent, decreased descent of the diaphragm, that can be a sign of tumor or lung collapse. Moving on to auscultation. So we're going to ask the patient to breathe in and out through their mouth, and we're going to be using a stethoscope. So also the 14 on this side, 12 on this side. But we have to be in contact with the skin as well, because that's what's needed to do the auscultation. And every time we move, the patient needs to breathe in and out every time we move our stethoscope. If we're moving too fast, we'll ask the patient to let us know if they think that we're going too fast. We also want to make sure the patient is shielding their breasts as well. And once again, if they're wearing a gown, they'll have to pull down or pull up their gown accordingly. So we're going to go also tape. So all right. And then with the breath sounds. So also, you want to make sure it's above the clavicle. So here, below the clavicle, they may need to pull down their gown. 4, 5, 6. So breath sounds, normal breath sounds would be like vesicular, so that's over the parenchyma, and then tubular, that's within the tubes, that's located in the tubes, and then adventitious breath sounds. So that may be due to like crackling, so that could have fluid of in the alveoli. And then there's also wheezes, so that could be due to obstructive lung disease. So this is the end of my lung